I want to say welcome to Osteo Boston tonight. To our Osteo Boston members, I want to thank you for getting on and for providing such great questions for our speaker at the end of her talk, as you always do, and being a very excited and enthusiastic group of people. I also want to thank our YouTube audience. If you're listening to this right now and it's a taped program and you like it, give us a thumbs up. If you want to subscribe, go ahead and do that as well. Pretty excited tonight to bring in Dr. Kim Millman. And I want to tell you a little bit right now about Dr. Millman. So Dr. Millman, it's her mission to get individuals to the root of their bone loss and reverse it naturally, so they can take better control of their bone health. She not only has a master's in molecular genetics, but she's also an MD with a PhD in epidemiology, population genetics, and bioinformatics, both from University of Southern California. She trained at Stanford in internal medicine, and later she became a leading edge researcher in infectious diseases at UCSF, San Francisco. She's completed over 25 years of postgraduate training in functional medicine and has been practicing for 15 years as an integrative medicine physician, treating over 600 patients for bone health in her Silicon Valley practice. With those patients, she's had a 99% success rate in preventing breaks and fractures. She is the founder and developer of a 14-week online program called Restore and Rebuild, 100 Days to Healthier Bones, that helps people identify the root cause of their bone loss and to determine an individualized program that will help them reverse the loss so they can continue to lead active and full lives. I'm really excited to bring up Dr. Millman with me. Thank you, Dr. Millman. We're excited to have you.
Thank you so much for having me.
You bet. Okay. We're excited. Would you like to start the program, or would you like me to, did you want to bring up slides, or would you like to say a little bit first?
Well, yeah, let me kind of introduce the reason why I got interested in being a specialist in bone loss in the beginning. So what I found out early in my career was that the diagnosis of osteoporosis was, number one, so common. It was, I would say that you know that it's the most common diagnosis among postmenopausal women. And I would say that 65% of my population in my practice is in that category. And then also when I saw the women and my patients when they first got the diagnosis, I saw, the real pain and anxiety and fear in their eyes. And they didn't know why it happened to them. They didn't know what to do. They weren't offered anything by their doctors except for medications that most of my patients didn't want to do. And I knew that I needed to figure out a solution for these ladies and my patients. And so I just dove right in, with my functional medicine experience and my engineering experience and my computational and genetic experience to really find what was working for my ladies with bone loss. And what I determined, which I think, many of us in the field have figured out, is that the bone is a dynamic tissue. It is a metabolic tissue. It is always communicating with the immune cells. The immune cells actually are the cells that are regulating the bone cells, and the bone cells come from the bone marrow. And so I realized that, and minerals regulate the bones, but they regulate the rest of the body. So what I realized was that a whole body approach was actually absolutely necessary, and that the bones were so metabolically rich that metabolically part of bone loss was absolutely reversible, and that if a person was to do medications, and I'm not completely against medications at this point in my career, but that the natural root cause part of it really also needs to be analyzed. And I've talked to Margie Bissinger about this many times, and we both say that this is really an opportunity to look at all of these things and for you to get healthier overall.
Oh, makes so much sense. It's fantastic. I love your the fact that you started out in a very traditional and also in genetics, and that you decided to get into functional medicine as a way to really help your patients. So I love that. Um, I know you talk a lot about the causes of osteoporosis. Did you want to touch on that, or did you, were you more wanting to start on your the slide program?
Yeah, I actually put together this presentation to go over 4 case studies. And these case studies will actually walk you through some of the tests that I get and how I interpret them and how I put together a protocol for these ladies. And I'd love to just get started so I could illustrate it for you.
That's great.
Okay. Okay, so I've put together 4 illustrative case study examples to help you see what I do as a functional medicine doctor with a specialty in bone loss and osteoporosis. So the first case study is a 63-year-old female woman who was diagnosed in 2016. And her mother broke her arm at the age of 76. And the surgeon at that time told her that her bones were crumbling. And then at 94, she broke her hip. And this was basically the end of her mom's mobility. She watched her mom go through this. It was very painful for her. And she really didn't see any other future for herself than to go down this pathway. She saw me on one of the summits that Margie Bissinger did in 2022, and she came into my practice. So just wanted to show you the beginning DEXA scans. So within 5 years, she had quite a loss at her hip. And then she had severe osteoporosis at the spine, and then moderate to moderate osteoporosis at the hip. She went to see her doctor at Stanford, and her doctor at Stanford recommended that she go on Forteo for 2 years and then a bisphosphonate. So she was worried about the side effects of medication, and then she came to me because she heard that I was looking at root causes. So her historical workup, this is the workup that was done before she came to see me. She had a calcium of 9.9 and a PTH of 26. And I love to use Diva Boone's parathyroid app and look and see whether or not that would be suspicious of hyperparathyroidism. So a calcium of 9.9 puts her right here. And that high of a calcium is going to suppress her PTH. And you can see that her PTH is in the low normal range. And according to Diva Boone's calculator, there's no indication of parathyroid disease. And so this basically ruled her out for hyperparathyroidism. She had a TSH of 2.0, which was completely normal. And what we're looking for in bone disease is hyperthyroidism. And so her thyroid was not hyper, or else her TSH would have been below 0.5, and it was normal. And her free T4, which is the inactive part of the hormone, was normal as well. She had a vitamin D of 60, and I like vitamin Ds anywhere from 50 to 70 nanograms per mil, and even up to 80. 86.7 in 2022 was a bit high for me. Her vitamin B12 was 393. I like vitamin B12s around 750. And her glucose was in the prediabetes range, 97 to 100. So looking at her initial lifestyle and her symptoms, anxiety and night sweats could be hormonal related. Sugar cravings were likely due to her blood sugar instability. She had some constipation, so she had some GI things going on. She was fatigued. She couldn't sleep. She had a low sex drive. She felt stressed, and she was not eating gluten already. And she had a pretty good diet with minimal sugar and processed foods. And she was exercising 2 to 3 times a week. So just by looking at her symptoms, I knew that I was going to evaluate her for stress and for hormones and for her gut and her blood sugar. So back then I was doing urine DPDs, and this is a bone breakdown marker. And as it's the higher it is, the more bone breakdown there is. And she had a normal urine DPD. So that was great. Then I looked at some autoimmune markers, and I looked at the thyroid peroxidase antibodies and thyroglobulin antibodies, and they were negative. I looked at some inflammatory markers. Highly sensitive CRP was optimal, but her homocysteine was 15.1. And so homocysteine is an inflammatory protein that gets elevated when there's B12, folate, and B6, and some other B vitamin deficiencies. And if you remember, her B12 was only in the 300s. So I was already suspicious that she needed some B vitamins added to her regimen. And in fact, a homocysteine of 15 can increase the risk in women of hip fractures. So her ferritin at 54 was normal. Ferritin can be an inflammatory marker when it's high, and when it's low, it can indicate that there's a lack of iron. And I wanted to evaluate her for something called a renal leak. And so what is that? That is when the kidneys are not reabsorbing the calcium appropriately. And so we look at the 24-hour urinary calcium to evaluate that. And anything under 200 is considered normal. And she was at 170. So I had ruled out a renal leak for her. For calcium supplementation, I had her do an estimate of the calcium that she was getting from food with an app called Chronometer, and she was getting approximately 400 milligrams. And I had her remove the very high oxalate foods from her calculation because the calcium in those foods are highly unavailable. So what she needed from supplementation was 1,000 minus 400, which she needed 600 milligrams of supplementation. And the best sources of calcium supplements, in my opinion, are the calcium chelates. That includes calcium dimalate and calcium citrate and some other calcium chelates. So these are some of the top oxalate foods that I have people take out when they're doing their calculation. Especially, I'm looking at things like spinach and chard and almonds and chia seeds and beets. And so these are the kinds of things that you want to take out because calcium is very unavailable in these oxalate foods. The amount of magnesium that I recommend is half of the amount of calcium that you get in your supplements. So she was taking 600 from her supplements, so she needed 300 milligrams of magnesium from her supplementation. And I also like the magnesium chelates. So the magnesium dimalate, magnesium citrate, magnesium lactate, and magnesium glycinate are my top favorites of magnesium to take in supplement form. So her initial protocol was calcium citrate, 600 milligrams. She didn't do the calcium dimalate because she already had calcium citrate. She took magnesium lactate and 300 milligrams per day. I put her on a homocysteine supreme formula that has the B vitamins in it that has been shown to bring down homocysteine. I put her on vitamin K2, MK4, 15 milligrams per capsule, 2 per day. I put her on 5,000 IUs of vitamin D3. I put her on a little bit of maca, which is good for hormone support. And she was taking collagen, vital proteins, 1 scoop in her coffee every day. So then I want to look at her hormones. And I did that by looking at the saliva, the hormones in her saliva. And you can see that in every panel, this is age adjusted. The green line is the optimal value. She was in the low normal range for her estrogen, progesterone, testosterone, and DHEA. So we looked at her family history of having breast cancer, and her mom's cousin had breast cancer at 70 to 80 years old. That is not a first-degree relative, so it does not count as a family history. She had never had breast cancer herself, and so she decided to go on bioidentical hormone replacement therapy. So one of the things that I do to be conservative is make sure that there's proper surveillance. And what I do is make sure that a woman has a yearly mammogram and an up-to-date gynecologic exam, including and sometimes a pelvic ultrasound that looks at uterine proliferation by looking at something called uterine stripe. And so she started DHEA 25 milligrams because remember her DHEA was low. She started on estrogen and progesterone, and she stopped maca. Some women will decide to keep on maca if they still have hot flashes with bioidentical hormones, but she was completely controlled. So she had her cortisol pattern was pretty good in the morning when waking up. It was on the low side at noon, and it was continued to be on the low side, and then it jumps up in the middle of the night, and she has higher cortisol. And this is one of the reasons why she's having trouble sleeping, and she's under a lot of stress because of her life. And so I gave her some adaptogenic herbs for stress support. Metagenics has something called serenogen, which is very calming. And I also gave her a little bit of rhodiola. So the food analysis, this is a Zoomer, a food Zoomer. And I'm going to show you the 2 different kinds of technology that you'll get in a Zoomer. So the first is the peptide level sensitivity that is shown in these bars of low and moderate and high sensitivity for that particular food. So for almonds, she had high peptide level sensitivity. And then all of these other columns here that you see, IgA and IgG, this is a technology that is less accurate and less specific. So for the peptide level sensitivity, these are very small fragments of a protein that is specific for that particular food. So for example, one of the proteins in corn, there's a corn aquaporin, and that corn aquaporin does not look like a soy aquaporin. So you can distinguish the difference between these 2 foods by looking at a peptide level sensitivity. And so I'm always going to take more credence on the peptide level sensitivity than this less specific technology. And so she was highly sensitive to almonds, cashews, egg whites, macadamia nuts, dairy, egg, and Brazil nuts. So we did not test gluten because this patient was already off of gluten. Sometimes I will have patients recheck gluten because sometimes they'll find that they have a reactivity to it, and it could be either inadvertent food that they're getting at a restaurant, or maybe some personal care product like shampoo or conditioners. So I recommended that she go off the very high reactivity foods, which were almonds, eggs, dairy, cashew, and stay off wheat. And so I added a digestive enzyme that could help her break down her food better and help her with her constipation, and a probiotic called Megaspore. And after 1 month, her constipation improved. And she also was not as tired. But remember, I also gave her some adrenal support. So we did some repeat testing. Her homocysteine went down from 15 to 11. I now know that I have decreased fracture risk just due to her homocysteine level. Her insulin was good. I look at a 2 to 8 being optimal, and insulin is the protein that helps you to drive your blood sugar into your cells. A1C is a 3-month average of glucose, and 5.7 is prediabetes, and she was just underneath that criteria. So she was showing that she was having a little bit of issue with her blood sugar, but her glucose went from 97 down to 90, so it was improved. We repeated the hormones, and you can see that her estradiol increased quite a bit, and you can see that her estradiol increased quite a bit, and her progesterone increased. Progesterone is really inaccurate in both the blood and the saliva, so I wasn't worried that this was so high. Her testosterone also increased, and her saliva DHEA increased. So her repeat bone density with the interventions that we did, she was on no osteoporosis medications of any kind. She had an improvement of 3.3% in her spine. And this is one of the things that I do see with BHRT, is that there's spinal improvements, but not really a lot in the hip. She did have an improvement in the neck of the hip in the shear, and this was not statistically significant, but she did have stabilization of her hips. So she was really thrilled because her night sweats were gone, and she had way better energy. She wasn't dizzy anymore. She was having regular bowel movements. She was happier. She was sleeping well. And at this point in time, we decided to reintroduce eggs because she was really missing them in her diet. So one of the things that I do is I do a 24-hour urinary calcium with no calcium supplements for 72 hours to evaluate whether or not the kidneys are absorbing the calcium that they should be. And then I have people go on to their personalized dose of calcium based on their food dose and their supplement dose. And once they're on that stable dose of calcium, I have them redo the 24-hour urine calcium on supplements. And I'm looking for that number to be lower than 300. And so she was. So now I know that her supplement dose wasn't so large that she was spilling that calcium into her urine. Repeat testing, I did a C-teleopeptide, and a C-teleopeptide is a breakdown marker, and its optimal level is from 250 to 350. So at 552, she was a little bit high. There should be a 10-to-1 ratio between C-teleopeptide and the bone formation marker, propeptide of type 1 collagen, or P1NP. And so 1/10 of her CTX was 55.2, and she was at 88. So this was really good, showing her osteoblasts were keeping up with her osteoclasts. Her DHEA was in a good range in the blood. Her progesterone and her testosterone were all within good blood ranges, but her estradiol was a little bit out of target. I was targeting her to be from 20 to 40, and she was at 12. And so we increased her estrogen based on this blood value. So her repeat bone density, she had another 4.4% improvement in her bone density. And she, again, her hips were stable over time, but what I find is when people are on BHRT, it's really the spine that is improving. So that's what she showed. She showed spinal improvement and hip stabilization. Her TBS was 1.265, and if you know about TBSs, they're only going to be looking at the TBS, which is a bone quality score, and that is, they only look at that at the spine. And her T-score predicted from her TBS was -3.3, which was exactly what her DEXA gave us, and that was partially degraded. So that was a pretty consistent TBS with her DEXA. She still had a little bit of stress and some anxiety, and we were still working on blood sugars, but her case had gotten quite a bit better. So case study number 2 is a 72-year-old woman who was diagnosed in 2007. She took Fosamax for a short period of time. She had GI side effects, and she had a tremendous drop. It was actually before this, but she came to see me in 2022 because her spine had dipped into the -3.6. So this was the severe range, and her hips weren't a whole lot better. In 2022, the TBS of her spine was in the degraded bone category. So her symptoms were really debilitating. They were mostly anxiety that were related to having IBS-like symptoms, so intense pain and having diarrhea. When she traveled, she couldn't eat for a couple of hours because she knew that she would be in the bathroom and suffering with IBS symptoms. She also in social anxiety type situations, she would be in the bathroom. Sometimes this anxiety was crippling and she would just need to go to sleep. She was having difficulty sleeping. She was lightheaded and she had migraines. So her glucose was a little high at 97, her calcium at 9.3 with a PTH of 26. This PTH is nice and suppressed. Her vitamin D at 31, it could have been higher for me, could have been 50, 60. Her CTX, this was before she came to see me, this was 350, so this was high, so she was likely losing bone. This did come down later on in the year. Her A1C looked great, which is her blood glucose measurement, despite the fact that her glucose was a little bit high, and her TSH was 1.5, which is optimal for me. So she got ruled out for hyperthyroidism. So when she first came to see me in 2023, her CTX was 398, which is above 350. So it looked like she was losing bone, and 1/10 of that would be 39.8. So her P1NP, her bone formation marker, was keeping up with her osteoblastic marker. And so because of her severe symptoms, I didn't wait for the functional medicine labs to come back. And so I began treating her for high cortisol and for overgrowth of bacteria. I also did functional medicine tests to confirm the diagnosis. I did a GI map, which is looking at the microbiome, and I'll show you that in a moment. And food zoomers, which I showed you in the previous case, which is looking at food sensitivities for wheat, dairy, eggs, and lectin. And then I did a Dutch for hormones and cortisol. So here's a GI map. So one thing that I love about the GI map is it looks at your microbiome and some other really important intestinal markers. And so this is a real-time quantitative PCR that is looking for the DNA of the different organisms in your stool. And so the way that you're looking at this quantitatively is that they're showing you how many particles of DNA that they found. So 1, e to the 3, if you remember your scientific notation, that's 10 to 10, 10 times 10 times 10, which is 1,000. And e to the 4 is 10,000. So this is 31.8 times too high reference range. So she had enterohemorrhagic E. coli. Now, that might sound scary, and it is a known pathogen, but most often these infections are self-limiting, and I don't need to do anything about them. She also had a bacteria in her stomach called Helicobacter pylori, and this is something that we in internal medicine will actually treat. So Helicobacter pylori can cause stomach ulcers, and in really rare cases can also cause stomach cancer. So it is not something that I leave alone, despite the fact that The reference range, her numbers were below the reference range, and her numbers were not in the red. And so, but I still would like to treat the H. pylori. Then here's the commensal keystone bacteria. So these are the good beneficial bacteria that you see in the gut. And so you want these to be in these green ranges. So she had Escherichia that was a little bit high, and she had Akkermansia muciniphila that was not detectable. Akkermansia muciniphila is a bacteria that secretes mucus, and the mucus protects the colon from the invasion of pathogenic bacteria. So it's helpful. And there are probiotics that have Akkermansia. It's relatively within the last couple of years that they've come out, and there are no probiotics that would take care of some of these other commensals, except for the spore-based probiotics. Excuse me. Okay, so this path, this shows you her overgrown or opportunistic microbes. Now, some of these are normal to have a certain amount of them, but you shouldn't have an imbalance of these. So when these numbers are in the high range and they're red, then they're going to cause a dysbiosis in the dysbiosis in the gut, and then that can cause leaky gut, where increased antigenic load can translocate through the barrier membrane of the gut into the blood, and that causes immune chaos. And remember, our bone cells are derived from immune cells. So she had an overgrowth of Streptococcus and Citrobacter, and so I knew that I needed to treat those. Steatocrit is, these are all very interesting intestinal health markers that can give you an idea of where your digestion is. So steatocrit is literally the amount of fat that is in your stool. There should not be any fat that would be found there. And when it is there, it means that you're malabsorbing fat. And so you need a digestive enzyme called lipase to break down the fat. And there's a digestive enzyme called lipogold that I use a lot when I find that. Elastase, her elastase was in the green, and elastase is representative of digestive enzyme capacity. So that could be like the peptidases and other, there could be cellulases, but basically your digestive enzyme capacity, hers was good. Beta-glucuronidase is a very interesting molecule that is secreted by pathogenic bacteria. And so when we have toxins that are going through the liver and going through phase 2 liver detoxification, one of the ways that we detoxify these toxins is to put something called a glucuronate molecule. And then that helps that molecule to become water soluble and ability for that toxin to leave the body. Your hormones are also metabolized through glucuronidation. And so when glucuronidase, that comes and cleaves the glucuronate off of the toxin, off of the estrogen molecule, and literally retoxifies that toxin, and that hormone sticks around longer and could become in excess. There was no blood that was found in her stool. And secretory IgA, this is the immune cells that are right at the surface of your epithelial barrier. So this is your, these are your immunoglobulins that are protecting you from pathogenic invasion. And so in her case, her secretory IgA was on the low side. Gliadin is a protein that's found in wheat, and so hers was normal. And eosinophilic activation protein is a protein that is found when you have allergic reactions to different foods, and that was normal. Calprotectin is an inflammatory protein when I have patients with Crohn's disease or inflammatory bowel disease, calprotectin can be in the thousands. And so hers was low. So it's not the only inflammatory marker that can be in the gut, but it is showing at least one marker as being nice and low. Her zonulin, which is a leaky gut marker, is very high. So 324 compared to 175. So it's almost twice normal. So she has a leaky gut. So we did her food zoomers, and she was sensitive to egg. So we took eggs out and dairy, lima bean, and this is her intestinal permeability marker, potato and wheat. So one of the things that people get confused about is this food zoomer is in the blood, and the GI map is in the stool. So you can have a reaction to wheat or gliadin in the blood, but not have that in the stool. And there is a way to explain that actually. So her wheat zoomer was 4.0 compared to, 3.8 compared to 6.0. So that was in the moderate range. And her leaky gut score was 3.7 compared to 6.0, and that was in the moderate range too. So I want to call your attention to a couple of the proteins that we look at in the intestinal permeability panel. Again, this is leaky gut. One is an antibody to zonulin. So remember, she had a high zonulin out in the stool that must have translocated across the membrane. The immune system saw it, made antibodies, and those antibodies went into the blood to cause immune dysfunction. Also, she had pathogenic overgrowth of colonic bacteria, and they have an outside shell called lipopolysaccharide, which is LPS. And she also had antibodies to LPS. So that meant that these LPS remnants had translocated across the gut barrier. Again, immune system sees them, reacts to them, and creates antibodies that go into the blood and cause immune dysfunction. Also, these are a couple of interesting proteins are the prodynorphins and the gluteomorphins. Prodynorphins and gluteomorphins, morphin sounds like morphine because these are molecules that gluteomorphin comes from wheat and prodynorphin also comes from wheat. These are substances that can actually have neurologic, addictive life-like reactions. So when these are in the blood, and for her, they weren't, if these are in the blood, these could cause reactions to food where you actually have a lot of cravings. So I also did the Dutch panel for her, and the Dutch panel is hormones and cortisol, and the hormones are taken in dried urine. And so just to give you a bearing on the way that these panels look, the postmenopausal range is this little purple box, and then the premenopausal range goes from this yellow star to this yellow star. So she was at the very bottom of her postmenopausal range for estradiol, for progesterone, and for testosterone and DHEA. At her cortisol was taken salivary, and her cortisol was very high in the morning, came down into the normal range here, high again, and high again. And so this extremely high cortisol explains some of her anxiety and also at night, her insomnia. Also, her insomnia sample in the middle of the night was 12 compared to 1. So she was really having a lot of cortisol that was getting ramped up at night. And this could have been something like anticipatory stress, just anticipating the day's stress starts to ramp up her cortisol in the middle of the night. So one of the things that I did, one of the things that I did, the treatments, was giving her DHEA, because here's another relationship is when cortisol is so high, and you can see it's high overall here, the cortisol postmenopausally is cortisol is made in the adrenals, and so is the DHEA. When cortisol is so high, DHEA is often very low. And when I give DHEA to women, they often feel a lot more energy and they feel a lot better. I also gave her DHEA vaginally for atrophy. I gave her progesterone at night, a plant-based melatonin, and her cortisol treatment. I also gave her some sublingual GABA and some phosphatidylserine and some cortisol managers. So I really gave her a lot of things to manage her cortisol. So in October, when she came to see me, she had not had an IBS episode in 2 months, which was incredible for her. She was feeling a lot better with stress, not having episodes of GI distress with her stress, feeling like she could handle it better. And then when she came back in December, she said that she was feeling like a completely different person, and she had had GI problems her entire life. And she said that she had never felt better. Okay, so and something that I wanted to also bring up is that when you have a cortisol that is like that and is so high, and stress is affecting that person so much, that person is in a sympathetic dominant state, and your digestion is a parasympathetic duty. And so you will never get a GI symptom to clear up if you don't clear up a high cortisol or stress in a person, because the digestion will just not get enough parasympathetic nerve stimulation because that person is in fight or flight all the time. So this person was a 67-year-old female with a diagnosis of osteoporosis in 2015. She had a large drop in bone density from 2018 to 2021. So you can see negative 2.6 to negative 3.4. She went on Evenity, which is good for both hips and spine. She had an improvement of positive 16%, which is a huge improvement in her spine, and a positive 6.4% in her hip. Her initial urine calcium was 439, way over 300. So this was a person with a renal leak. So this is a person who is not, her kidneys are not reabsorbing calcium. And the medical treatment for this is hydrochlorothiazide. Another physician was taking care of that for her, and started her on hydrochlorothiazide. Her potassium is on the low end of normal because that's what hydrochlorothiazide will do. Her CTX was 504, so this was pretty high. And her 1/10 of the CTX is 50, so her P1NP was way over 1/10, so that was good. Her vitamin D was good, and her 24-hour urine oxalates were 41.5. This is a woman with kidney stones. So her kidney doctor was following her for her renal leak and for her oxalates. And so she went on a low oxalate diet, and her kidney doctor wanted her citric acid level to be over 600 because citric acid will help to combat your oxalates. Her TSH was 3.4, so she was ruled out for hyperparathyroidism. And then after the diuretic had started to work, her 24-hour calcium went down from 439 to 273, showing that the diuretic was working, and her PTH was nice and suppressed at 30. So she had frequent urination, probably because of the diuretic, often thirsty. She had some symptoms from stress. She had some insomnia. And like I said, she had a history of kidney stones and a renal leak. So some of the things that we did was we estimated her calcium from food was estimated pretty high, actually, because she ate a lot of dairy. So she needed 200 to 400 milligrams from supplements. And so I recommended that she take calcium citrate because citric acid is something that helps to combat oxalates. Citrates do as well. So when a person has an oxalate problem, then the recommended calcium form would be calcium citrate. So she was taking 250 milligrams 1 to twice a day. I prefer Perfect Amino. It's a protein powder that is made of amino acids that are in the bottleneck of making proteins. And so because of that fact, it is more efficient at making proteins within the body than food itself. It's more efficient than eggs, than meat, than dairy, than whey protein, and then collagen. So I like Perfect Amino. I had one patient last week actually tell me that she's sure that she was feeling very sarcopenic when she came to see me. Sarcopenia means that there's muscle wasting, and that she felt like she had gained more muscle mass, and then she was very diligent about taking her Perfect Amino twice a day, and she was sure that that's what had made the difference. With oxalates, there's depletion of some minerals and some electrolytes, and one of the vitamins that oxalates deplete are B6, and P5P is the activated form of B6. So I gave her some P5P. 40,000 volts is an electrolyte drink that I like. It's got sodium, potassium, chloride, boron, sulfate in it, not very much sodium. So for people who have high blood pressure, it's good. So I have people take a big mason jar of water, squeeze a half a lemon into it, and add a teaspoon of 40,000 volts and just drink that during the day to help them with electrolyte repletion because of oxalate toxicity. I had her change her vitamin K to Ultra K2 because I'm a big fan of vitamin K2, MK4, 15 milligrams twice a day. Boron has been shown to reduce calcium in 24-hour calciums. And so I put her on some boron. And then her kidney doctor was telling her to have at least a half a cup of lemon juice per day. So her A1C was optimal. Her CRP, which is inflammation, less than 1 is optimal. Her homocysteine was great at 5.2. Insulin, my optimal is 2 to 5, and she was at 4.7. And her ferritin, which can be if it's high, it can be what's called an acute phase reactant, which is inflammatory. But if it's low, it could be the storage form of iron. It could be low iron. She had a GI map, and she had Helicobacter pylori. She had a lot of greens in here, except she had a low Enterobacter and low Akkermansia. Because of the low Enterobacter, I gave her something called Megaspore, which increases diversity. And then later on, I gave her something called Metabolic Daily that has Akkermansia in it as probiotics. She also had an overgrowth of Morganella, Pseudomonas, and Streptococcus. So I gave her 2 different antibacterial herbal regimens to help and mitigate some of this high bacteria. She had no fat was found in her stool. Her digestive enzyme capacity was good. She was not retoxifying her estrogen or her toxins. She didn't have blood in her stool. She did have low immunoglobulins. She wasn't reacting to gliadin or having allergic problems. Her inflammation was low, and she had a leaky gut. So I put her on some colostrum to help her secretory IgA and her zonulin. So after taking out high oxalate foods, her 24-hour oxalates now go down from, I believe they are in the 40s now, down into the 30s. Her citric acid is climbing up. and her 24-hour calcium is 376, which is above 300. So I had her decrease her calcium dose slightly. And so she was feeling an improvement in her energy, and she felt like she had a reduced body fat with the perfect amino. So her repeat bone scan, if you remember, she was on Evenity, so she had a 16% increase in her spine. And after a year, she had a 1.8 increase in her spine, and her hips continued to get better. So this is the last case study that we're going to do. So I have a 56-year-old female diagnosed in 2020. She has osteoporosis or osteopenia and osteoporosis in her hip. She had thyroid disease, Hashimoto's, so she was often tired and she was constipated, but she could be tired and wired at the same time. She had insomnia and headaches, and she also had a history of small intestinal bacterial overgrowth. So her glucose was optimal at 87. Her A1C was optimal at 5.3. Her TSH was 0.18. This is a little bit suppressed, but it was because she was on armothyroid that has a little bit of T3 in it. Her free T4 was normal, so she was not being over-medicated. Her thyroid peroxidase antibodies were super high, so her Hashimoto's was flared. Her vitamin D was in a pretty good range for me, and her calcium was 10.1 with a PTH of 62. So you can see in Diva Bones app that a calcium of 10.1 should suppress the PTH down into this range, but it did not. Her PTH was still high at 62, and according to Diva Bones app, this is consistent with primary hyperparathyroidism. So when there's one autoimmune disease, there can be others. So I tested her stomach for antiparietal cell antibodies. These are antiparietal the parietal cells are the cells that make hydrochloric acid in your stomach, and intrinsic factors are the things that help your B12 to be absorbed in your stomach. And she had positive antibodies for both. And as far as inflammation went, her C-reactive protein was nice and optimal, but her homocysteine was too high, so she was inflamed in that category as well. So she, again, her calcium is climbing even higher, and I'm talking with her, and I'm having her talk to her doctors about possibly having hyperparathyroid disease, and they said no until the parathyroid is abnormal. Actually, let me show you this number. At this point, her calcium was not abnormal and her PTH was not abnormal. So they said no. When I found her calcium to be high and her PTH to be high normal, they were starting to listen, and they were starting to say, okay, maybe there is something here. So her initial protocol, I did not give her calcium supplements because her calcium is running high. I did give her vitamin K because I want to push that vitamin K into the cells, and that's one of the jobs that vitamin K does. I gave her magnesium. I added some homocysteine supreme, which is a bunch of B vitamins, and I gave her B12 shots for a few months because she had autoimmune pernicious anemia. And so the antibodies against intrinsic factors means that it's going to be harder for her to get her B12 absorbed because of those antibodies. So we did a further analysis, what we did was assess the MEBI nuclear medicine parathyroid scan, which showed a 0.6 centimeter parathyroid nodule that was most likely a benign adenoma. So we convinced her surgeons to take out 2 parathyroid glands, and her calcium and PTH just came right back into normal. I did a GI map with her. She had some low probiotics and some H. pylori and some overgrowths. And she had an very high reaction to gliadin. So I took her off of gluten, but this was something that she actually kind of fought a little bit and didn't want to stay off of gluten. Her next bone scan was she dropped in the spine by -6, and then her hips were pretty stable here and pretty stable here. I believe that if she hadn't gotten the parathyroid surgery done, that we would have seen an even more dramatic decline. So that's all I have to share with you. I hope that you learned something from my case studies.
That is awesome. Let me just bring myself back up. That was so informative, and you've already had so many questions, but it was so informative, and there are a lot of questions I have as well. You went pretty fast.
All I'm going to say to everybody is please don't be overwhelmed. If you can just pick up one or two little pearls in that whole discussion, like what is a renal leak? Like, you know, what should I be doing if I have, you know, a higher than 10 calcium? You know, how much calcium should I be taking and what type of calcium? I mean, there's a lot of little pearls in there that I know that your audience is very savvy, and so that, you know, I think if you can just pick up a few things, I think it helps.
I thought that was great. And I also, you know, I noticed that you talked about that the trace minerals being able to be provided by that bolt. What was that?
Oh, 40,000 volts.
Yes.
40,000 volts. Yes.
Is that something you buy online? Is that something we could find at a store?
You can get it at Full Script. If yeah, so it's a Dr. Line product, but I know that some of your people probably have Full Script accounts.
Mm-hmm. And also, I guess, what do you think of mineral water, alkaline water? How do you perceive that, since you did bring that up a little bit?
Right. Well, so I used to have an alkaline water machine and kind of got into it when it was kind of all the rage. And I think people still have them. I'm not sure that the pH of the water really makes that much of a difference. It's just that getting those electrolytes in, and if you have a reverse osmosis filter, then you're losing all your minerals. And so within that filter situation. And so that's why I like to do things like the electrolytes with 40,000 volts, or make sure that you're taking trace minerals.
I also know you talked about a class that you teach called the Rebuild and Restore class.
Mm-hmm.
Is that something that you are still offering? Is that something we might participate in?
Right. So right now I'm right in the middle of my my second launch. We did one launch last year, and we just started 3 weeks ago. And so this is going to go through June or July, but there's going to be another class that's going to be starting in August, September. And if people want to get on the wait list, there's they can go to my website, and then there's a button that says join the wait list. So, and there's all kinds of information about it. They can look and see if it looks like it's something that's right for them. And I can type it's the Millman Clinic.
Mm-hmm.
.com/R&R.
Great. It's awesome. I know I have a million questions, but I feel like I will hog this whole thing if I don't get to some of the other people's. So let me go ahead and ask you some of that. Claudia asked, can renal calcium a leak of renal calcium that is be caused by insufficient estrogen levels, estradiol levels, and what is that relationship? Or is there a relationship?
Well, that's kind of interesting. The more I learn about hormones, it's like kind of like what can't they do, right? And how like, and I don't, um, you know what? I believe that a deficiency of estradiol does cause you to leak calcium.
Okay.
I'm pretty sure that that is.
Mhm.
True. Because for one thing, calcium is your anti-resorptive hormone. It is not your bone building hormone. It is stop the breakdown, not form. So the formation hormone is progesterone. You have to have both. If you're missing estrogen, then you'll break down more than progesterone will help you to form. But it is really, and it's exemplified by the fact that when you go on bioidentical hormones, CTX decreases with estrogen. So CTX is your bone resorptive hormone. So that's the osteoclast breaking down. And so CTX goes up when estrogen is too low. And then when I put women on estradiol and their CTX comes down, and maybe that one particular case where my patient was not in the right range that I wanted her to be in, I upped her estrogen and we saw a direct correlation with her CTX coming down.
Very interesting. Very interesting. And I never heard it explained that way either, that, calcium is anti-resorptive. And
It absolutely is. And remember too, is that, if you have low estrogen and you're breaking down your bones, you've got a lot of calcium that are being filtered through the system, right? And so you're likely to have more of and a renal calcium leak is really that the kidneys can't reabsorb enough. But it's really a kidney problem. But the 24-hour urine calcium can go up just because there's more being filtered through the system. If that makes sense.
Very interesting. People asked about cortisol here. What if cortisol is really low in the morning? How do you raise it?
Well, there are all kinds of adrenal adaptogens. First of all, never let loose of the site. What am I trying to say here? Don't forget that and maybe your audience don't know this, but the adrenals love B vitamins, love vitamin C, love protein. So that's the first place to start, right? Are the adrenals nourished? So, and one of the ways that you can look at your B vitamins are it's the homocysteine level. And so if the homocysteine is high, you get more B vitamins in. And absolutely make sure that you're taking enough protein. But then there are also herbal adaptogens that can be helpful. Rhodiola can, some of these are neutral, some of these can raise a little bit. The one that really raises is licorice. But you have to be careful with licorice because if it's not deglycerinized licorice, which is DGL, which helps with gut problems, you have to take the glycerinized licorice for the adrenals, and that can raise blood pressure. So not very many people can really take a licorice formula, but I do have some people who can do that. But things like rhodiola and ashwagandha and there are a lot of adrenal adaptogens that can be helpful just to overall nourish the adrenals.
It's good to know. Okay, that is excellent. Thank you for that answer. Now, Betsy asks, in all of the cases, the T-score for the spine and hip were fairly close. If they are pretty far apart, for example, -1.8 at the hip and -3.6 in the spine, does that suggest there may be something going on specific to the spine?
Well, I mean, I've seen this play out many times where the spine is worse than the hip or the hip is worse than the spine. I'm not really sure about what factors could contribute to that. She might be thinking about the fact, though, that if you have a this goes in the other direction, though. So if you have a spine with a lot of arthritis in it, the DEXA scan will look better than it actually is. And the reason is because there's extra calcifications. Also a compression fracture, you think about it, it compresses the vertebrae. So when it compresses the vertebrae, it gets more dense, right? So I'm not sure if that's what she was getting at. For sure, there are there are medications that don't do as well on the spine as in the hips. That's a completely different question.
I understand what you mean. And I think, it's interesting. That's one of the reasons we're having the REMS technology come, is because it does pick up whether or not that bone quality is accurate, or if it's arthritis, or the architecture's off. So people are asking, how would we be able to see you? And I know we're from all different states. Is that limiting?
Well, right now it is. We're booked out until August. At one point I was taking some out-of-state patients where they were flying in. They would fly in for their first physical visit, and then they would get 1 year of telehealth from that point forward. And we were doing that right around the time that the class had started. And so we had 20 spots, and they're filled right now. And so probably if you're from another state, we have to check in probably more like July and see if we're taking out-of-state patients again. But if you're in California, I can see a person completely over telehealth.
Okay. That's good to know. If someone took your class, for example, would they be able to glean things from that to be able to practically use on a practical basis right away? Or would they need to actually be in California to participate?
Yeah, so the class is actually set up a lot like these case studies were. So I'll do a didactic, like, so for example, this module, module 4 is on the gut. So we're going through food sensitivities with the food zoomers, how to interpret them, and then we're going through, not that they're rocket science, but they're they're not that hard to interpret. We're going through an elimination diet. If somebody doesn't want to do the food zoomers, they could do an elimination diet instead. We are going through the microbiome and its relationship to bones, and we're going through the GI maps and how to interpret those. And then right now I'm actually looking at what are the probiotics that, if you take these particular probiotics, have they been shown in either mice or humans to improve BMD?
Very good. Okay, so in other words, we would be participants in that class, and then we would learn ourselves what supplements to take and that sort of thing. Okay.
Right, and then they're allowed to join my FullScript account and then they can buy the doctor's brands with the full script account. And then the other thing is that I have a testing webinar, and I have a huge testing guide that gives all of the LabCorp, a lot of the testing that I did in these case studies. I have the LabCorp and the Quest test codes for if their doctors want to do it. I have Life Extension and Ulta Lab codes for if they want to do direct to consumers. And I have all the codes from DHA and from other places. So if they want to get the functional medicine labs, they can do that on their own.
In terms of the bioidentical hormones that you treat people with, how would they be able to access those?
Only if I was a prescribing doctor. Yeah, they're prescription only.
So would they need to be a resident of California?
Yes.
Okay.
Yes, and I'm really looking at oxytocin these days too.
It's good to know. Okay. Let's see. How does one's parathyroid gland play into osteoporosis?
Yeah, so what happens is that the parathyroid, when the parathyroid hormone goes up, calcium in the blood goes up. And that is because the calcium is being stolen from, well, first of all, the gut, the absorption from the gut increases. And then also the calcium leaves the bones and goes into the blood. So the PTH is like all hands on deck, bring the calcium into the blood.
Wow.
And so when you lose your calcium, you're going to break down your bones.
It's pretty important. I know we've had people on this in our group that have had parathyroid. It's very obvious when that marker comes up. I know that we've been talking about estrogen levels and DHEA and progesterone.
I'll take two. Thanks.
Is
Resist the cash.
someone mute?
Thank you.
Someone is talking. Would you mind muting, please? Thank you. Anyway, I'm just wondering, what if someone is part of your practice that cannot take estrogen, or they have a family history that's, their mother or their sister? What do you recommend then?
Yeah, I think it's possible to take oxytocin actually. So oxytocin, maybe I haven't done enough research on this yet to be definitive, but there are some studies that are showing that it could be a treatment for breast cancer.
Wow, that's great.
Yeah, so possibly oxytocin. And I was looking at one of my one of the probiotics that I was looking at. I think it might be L-plantarum. But one of the ways that it probably increases bone mineral density is by acting through oxytocin.
Wow, that's very interesting. I've heard of oxytocin in reference to something else. I'm trying to think why is that such a familiar term for me?
Pregnancy.
Thank you.
Yeah, it's the love hormone.
Yes, that's it.
It's the love hormone. It is so it's going to go up when you hug someone, when you kiss someone, when you have sex, when you're breastfeeding. And so, but what
Don't
they're
forget labor.
but when they're labor too, yeah. So but what they're finding is that as an anti-aging molecule, it could be super, super important because our oxytocin levels drop off. And they're looking at it in response to osteoporosis, dementia, diabetes, cardiovascular disease, obesity. So they're looking at it as being a potentially an anti-aging medication.
Wow, that's really exciting, actually.
It is really exciting.
I loved that you brought up about oxalates today.
Mm-hmm.
And how important they are. how long do you feel like after you've taken an oxalate, would the calcium be able to be absorbed into the body? Like, when would you take your calcium? Let's say you had spinach at lunchtime. When would you be able to take more calcium and have it be absorbed?
I don't know the answer to this question. My intuition just tells me that it would be probably likely be like the next meal.
Yeah.
And I think it also depends on the transit time of the gut, right? There's different, different people have different transit times. So how fast is that moving through? How fast is that person absorbing? So there are a lot of individual, that's why that might be different. But I can't imagine that and another thing that I tell people to do too is if you have a spinach containing meal, you should take like 150 milligrams of calcium citrate with it.
Oh, to counterbalance it?
Because the citrate helps to combat the oxalate.
Oh, that's great to know.
Yeah, it's really the citrate. It's not necessarily the calcium, but it's the citrate.
Yeah, that's wonderful. Thank you. So informative. All right, and let's see. Someone asked more about hormones. You mentioned the Dutch and the saliva testing. Is that the same thing?
Well, no. So for hormones, the Dutch is dried urine, and then the ZRT that I showed was the saliva. So the Dutch for the hormones and cortisol is $400, and then the ZRT is about $250. So my patient just opted to have the cheaper test. And then I'm also going to be doing blood hormone levels as well. And some insurance is going to pay for that. So
Sorry, Dr. Millman, which one do you actually prefer, the urine or the saliva? I know, blood is only kind of a moment in time, but which one are you in favor of?
the Dutch. I like the Dutch. Just because the Dutch is so much more comprehensive. I didn't show you the other parts of it where you can look at the metabolism of estrogen and see whether you're going down a proliferative or a protective metabolite pathway. And so I think that's really important to look at. And it's got the cortisol awakening response that is a good surrogate marker for how well your brain is talking to your adrenals through the HPA axis. And so I just think that the Dutch is well worth the extra money.
That's excellent. Someone asked about the rhodiola rosea supplement. Is there a specific brand you recommend for that?
No, I mean, I often use Designs for Health. I use Pure Encapsulations, Thorn. There are different combinations of different, there's Designs for Health has something called, it could be Pure Daily Stress Support, which I think is really kind of a nice combination. For cortisol, for dampening cortisol, I love Cortisol Relief by Vitanica. Love it.
Thank you.
And I don't know if it has to be from Siberia or not. I really don't.
Sorry. Is a pill as good as a powder for calcium citrate? What's your take on that? How do you usually recommend it?
I think probably the answer is yes. I don't think that there's much of a difference. Maybe if that person has really a gut that's pretty broken down, that's not absorbing very well, maybe no.
Too. I know you talked about people's glucose levels and, you know, how to determine whether or not that is a problem with your bone loss as well. And you mentioned in something that I was listening to that to bring down the glucose levels, it's not only important to look at that and how, but to actually look at how you're eating. And when are you eating your protein? And could you talk about a little bit about the fats and the protein and the fiber that you,
Yeah, of course. Yeah, of course. So I am a big fan of continuous blood glucose monitoring. And so, because of the fact that you can really get a real-time look at what foods are doing what to your blood glucose, right? And but there are a couple of ways that you can, what we want to do is we want to decrease what's called a glucose spike. So the glucose spike is your peak, the peak at which after you've eaten minus your baseline, which is the glucose right before you eat. So you want to limit that spike to about 30 points. And so there are all kinds of methods of being able to reduce those spikes. One is food combining. So if you have a carbohydrate, you can combine it with fat and fiber and protein, and that will help to flatten that glucose spike. Food order. So if you eat your carbohydrates last, so if you eat fiber like a vegetable, there was a study that was done, and the meal was ciabatta bread, orange juice, chicken breast, a salad, and some broccoli. And so when they had the ciabatta bread and the orange juice first versus when they had it last, there was a 50% change in their insulin level and about a 40% change in their glucose level. It was really super dramatic. So if you only change the food order, if you have your salad first, you have your bread last, you have your protein first, you have your bread last, you know, it can make a huge difference. Also, taking a 10-minute brisk walk can help. Apple cider vinegar, taking a teaspoon in a little bit of water 30 minutes before you eat. Always being, you know, a stress ball, that's not a good thing while you're eating, because you've got sympathetic engagement and no parasympathetic engagement. You need the vagus nerve to be talking to your gut in order for your gut to process food. So all those things can actually really decrease your glucose.
that's really, really helpful. I mean, who would think that their food order would make that much of a difference? But that's something everyone can do. It's
Yeah,
really-
you don't need a continuous blood glucose monitor for that.
Yeah. Now, how does one go about obtaining a continuous glucose monitor like that?
They're prescribed. Well, okay, so I can prescribe one to my patient and they can get it probably at the lowest cost through prescription. And the insurance companies are not going to pay for it unless there's frank diabetes. So if it's just pre-diabetes or if it's weight loss or something like that, they're not going to pay for it. I have found that Costco has a pharmacy coupon, and that it's like $75 off. And so there's one sensor will last 14 days and two sensors for a month will be 150. But when you use the $75 coupon, it's $75 a month, which is pretty reasonable. And then they've got these direct to consumer companies like Levels, and I don't remember many of the other ones, but they could be in like the $250 a month range.
Oh my goodness. Well, I'll have to get Costco memberships, I think. It sounds very good. Oh, that's great. Okay. Let me see. I think I had one other question, if you don't mind. I know we've gone over time by a lot, but it's so fascinating. You've talked a lot about the pulsed electromagnetic field, and how that works out with, you know, the blood thinning and.
Well, so the PEMF devices, I've had one for now 5 years, and they're FDA approved for fracture healing. And so that Dr. Pollock is probably the world's expert in PEMF. And so if you want to get like have him on your program, I'm sure you would love listening to him, because he can dive really deep. But basically, I think the story is true. The cosmonauts came back from the space station, and they were trying to figure out some way to help them to recover as quickly as they could. And so they figured out a frequency that was similar to the gravitational pull of the Earth. And then that is the frequency that the PEMF devices are delivering to a body.
Yeah.
So there you have a generator that's delivering these pulses. And then you either have, like, I have a mat that I lay on. So there's a coil inside the mat that is pulsing, and it's pulsing through the mat, and then it pulses onto the body. And it's very, very therapeutic. And so it's been found FDA approved to help with back fractures. And I know a lot of, I have a few patients who have like the Beamers, which are low frequency PEMFs to help them with their bone density. They just feel an overall sense of wellness when they use the PEMF devices. I've got a big clinic device, which is 1.5 Teslas, that is, can help with big injuries that you wouldn't probably use. You wouldn't use that for bone density, but I think it could make a difference.
Yeah. Wow, that's really interesting. Let me just make sure that I didn't miss anybody that's asked me more than one time. Okay, one last question, if you don't mind. This person did a CTX test, and it was high in the 760 range. Should someone do a P1NP test, and if they did, would you expect it would be low?
Not necessarily, no. So I always like to look at the pairs, right? Because so 760 is quite high, right? So it's way above 350. Most people are going to be losing bone at 350, 400, 450. People are different. And a P1NP to be for the osteoblasts to be keeping up with the osteoclasts need to be around 76. It's funny because I find that my patients are having nice, robust P1NPs. And I think that the reason why they do is because I'm recommending vitamin K2 at high doses. I'm recommending perfect amino. So, the protein and collagen can really help the P1NPs, and exercise can really help the P1NPs. So in my course, I have a framework for what are the things that increase formation and what are the things that increase breakdown. And so if your CTX is on the high side, you want to decrease breakdown. So focus on these factors. If your P1NP is not robust enough, then you want to focus on these factors that increase formation. And those are your nutrients, like your vitamin K and your calcium and your magnesium and your and exercise and protein.
That's great. Oh my goodness. So much information. I'm so excited. We're going to have to listen to this again. And it just was a fantastic talk tonight. I'm very appreciative, Dr. Millman.
Yeah.
And I know that you'll have a big fan club with Osteo Boston. I really appreciate your time tonight.
Well, that would be wonderful. I would love that.
Yeah. We're going to look for the next Restore and Rebuild. It sounds like something that I would personally like to do. So,
well, I will keep in touch with you, and maybe we could send out an email when we're starting to relaunch it.
that would be great. That would be great.
I could probably also give a coupon to your members.
Oh, that would be even better. We'll take it. Anyway, thank you. And thank you, everybody's thumbs up and thank you. Very appreciative. And
Wonderful.
we will be talking to you, Dr. Millman.
Okay, that's awesome.
Thank you.
All right. Bye, everybody.
Thank you so much. We're really appreciative. Wasn't that great?
Wow.
Right?